up front. And that EAPs, while they have been around for years, just don't seem to always cut it. And so what we want to do on this panel is to focus on the question of, well, how do you integrate behavioral health services into a primary care setting? What is the approaches you need to take? What are the issues and challenges you have? What's the benefits of this? And what's this all about? So with that, I'm going to ask each of the panelists if they'd introduce themselves. So I'll start out with Amanda.
Hello, I'm Amanda Giebert. I'm the benefits manager at Sargento Foods. I've been with Sargento for a little over 2 years, but I've worked in the benefits space for quite a while with different organizations, whether it's been at Sargento, we have an on-site health and wellness center, but I've also worked with employers that have the near-site kind of collaborative community wellness center opportunities as well. And we actually implemented a behavioral health kind of on-site health work-life mentor is what we call it, stigma removed. Work-life mentor at our on-site health and wellness center over the past 2 years. So I'm excited to talk about it.
Thank you. Monty?
Sure. Good morning, everyone. It's so awesome to be here in Minneapolis. Monty Maston, Chief Medical Officer with Marsh McLennan, based out of Atlanta, Georgia. I lead a national team that is deep into data analytics, population health, and clinical consulting. We work with hundreds of employers across the country. And what was really interesting earlier, you heard about data integration. We take over 150 different data points into our data platform and look at ways that the clinics are actually performing better care at lower cost than community-based providers. So I'd be happy to talk about that later, but certainly mental health, big challenge for all of us.
Thank you, Daisy.
Good morning, everybody. I'm Daisy Brayton, and I'm the Human Resources Director at the City of South Burlington, so I'm in municipal government.
That's in Vermont.
In Vermont, yes, thank you. And I should say I am a new Vermonter. Grew up in LA, went to high school and college in California, spent 30 years at the University of Nebraska-Lincoln. Go Huskers. Will always be a big red, big red. And yeah, oh, that's okay, you're forgiven. I am new to Vermont, been there for about 6 months, and am also relatively new to the we have a near site health clinic at our organization, and I have drank the Kool-Aid and am ready to talk about our success.
Excellent.
Hi, I'm Erin Dace. I'm a psychologist and National Director of Behavioral Health for Marathon Health, which you saw Jeff Wells up here earlier talking about us a little bit. I came from academic health centers doing clinical work for a long time and transitioned over into the employer-sponsored healthcare space. So happy to talk more about some of the barriers and challenges and opportunities of providing these services to your employees.
Thank you. And last but not least, Dan Conte.
Hi, I'm Dan Conte. I'm a clinical psychologist by profession. I spent 30 years at J.P. Morgan Chase surrounded by bankers, where I directed the Employee Assistance and Work-Life Program globally. When I left, we had 28 clinics in the United States, 16 of which had behavioral health clinicians working in them. We expanded into London, and we put one there. Since leaving J.P. Morgan Chase, intact, I now am with Health Next, a group that is looking at assessing and providing roadmaps for employers who want to build a culture of health. And I'm enjoying retirement life very much.
Yeah, so I dragged Dan screaming and yelling back into this area. So when I was the Midwest Business Group on Health CEO in Chicago, we had a very good long relationship. So thank you for coming back to us here. All right, so let's get started. Again, we'll use the same approach. I'll ask a variety of questions, and then, again, my text number is 847-606-5527. Just send them to me, and as I said, I'll ask those following the general comments we have of the panel. Or again, you can write it down on a note card and just hold it up. Let's start out, Amanda, then. What's been the impact on the pandemic of behavioral health use since then?
That's a really loaded question. Clearly, mental health has always been out there and always kind of been an issue, if you will. It's just the Okay, and the pandemic just kind of brought it to the forefront, to be completely honest. It's always been here, it's been here for a very long time. A lot of people, for the most part, it was brushed under the rug. And the pandemic, it brought behavioral health to the forefront to essentially make it okay to have mental health struggles. A lot of people were, as we all know, confined to their homes. A lot of people were isolated, especially those living by themselves. Really didn't have an outlet, which exacerbated essentially the pandemic of mental health. So I think COVID in and of itself brought it to the forefront, and I'm really actually grateful for it from the standpoint of that it's brought it to the forefront and made it something that more organizations are taking a focus on, more community members are taking a focus on it, and people are actually starting to go get the help that they need without as much of a stigma.
Thank you. Monty, your perspective on the impact of pandemic and behavioral health?
Sure. I would say, just like Amanda said, that this existed pre-COVID, exacerbated meaningful during the pandemic, and certainly even as COVID exits stage left, it's still going to be a challenge for employers. Three things that we've seen: up to 40% of the mental health claims for an employer, typically under Marsh, are coming from the dependents. So, your employee may be fine, but you have no idea what kind of environment he or she is going home to. Maybe a troubled kid keeping her up at work, keeping her up late at night, she comes to work tired, less productive. Maybe there's safety issues involved, it's in healthcare or manufacturing, etc. The other thing we're seeing is a lot of ED utilization, 25 to 35-year-old males driving a lot of emergency room utilization for behavioral health conditions. They haven't invested in primary care home. They're healthy, they don't have preventive health care needs, but when they start feeling blue or down, they have nowhere to go, so they end up in the emergency room. And then, the integration of mental health into the behavioral health clinics. One of the toughest employer meetings I had in the last few years was a large manufacturer in Ohio. And we were looking at the high-cost claimants, and that year, 4 out of the 10 most expensive people on the plan were male employees who had attempted suicide, and unfortunately one survived the initial attempt but then passed away. And that employee had sought care for weeks at the plant. They had a clinic, but they did not have behavioral health resources. No one knew really how to direct them into the EAP or to get them into community resources or health plan. So if there had been an integrated mental health model for that clinic, maybe his life would have been saved.
Thank you, Daisy.
I look around the room and I see no masks. How quickly things change, right? I mean, where were we just a couple of years ago? We talk about the pandemic and the impact that has had, but remember what was also happening during the pandemic. We had social unrest, we had political unrest, we had wars starting in the world. We had the perfect storm. We had everything happening at the same time. And where mental and behavioral health has always been such a stigma, now we need to really pay attention. And we started, and when I say we, my organization or the City of South Burlington started to pursue having behavioral health in our and actually even the medical clinic, the near site medical clinic during the pandemic. Really, it is a brave new world, and we have a lot of different approaches that we have to consider and have in our toolbox. So I think every single one of us is sitting here and remembering all the challenges we had during the pandemic. And literally, I learned how to spell pivot forwards, backwards in French. I mean, you just were always pivoting because everything was changing. And that is really how and why the focus on behavioral health and mental health really has to be at that forefront.
Erin, your perspective?
Yeah, I'll agree with everyone that's spoken so far. I think I will add to that the access has become even more limited. So despite the fact that there are different types of access now, we've made huge moves forward in terms of behavioral health, of of the places that people can go, the ways that people can access care. But in terms of a mental health clinician being available on the other side, has become even more limited. And if we talk about the pandemic, clinically, many clinicians have left the field entirely. Many of them have removed themselves from those traditional health system, academic health system practices, which makes it and puts up even more barriers for individuals when they're at that point of change that I'm sure we'll speak more to, of being able to manage all of those and being able to access this. And they talked about deserts earlier, right? It is massive across the country, the ability to have places and have somebody on the other side when you're really looking to get that kind of help.
Thank you, Dan.
Certainly, everybody's right here. There's no doubt about it that the pandemic had a significant influence on behavioral health care and need for health care, et cetera. I'm not going to repeat all that, but something else I've noticed anecdotally is that I've never seen so much social media and communication response or proliferation around mental health. And I think it's going to stay that way for a while, which is going to feed the access issue and hopefully, again, increase adherence and access. Well, I don't know about access, but increased need for care. And the last thing I wanted to mention also is I saw post-pandemic is, perhaps Monty can relate, I have a number of friends who are physicians who talk to me about the burden now of being in primary care and not being able to rely upon integrated mental health care for the patients that they're seeing. 75% of whom, estimated, probably bring to the office some mental health problem along with whatever primary care reason brought them there.
Thank you. And Dan, let's go back to you. Most employers had an EAP available to themselves. Is that enough for behavioral health? If not, why is it not enough? And historically, what's been the utilization and how's that changed?
You know what's frightening is typical average utilization in the United States for EAP still runs around 4 or 5%. Right? I'll brag. JPMC, we had a utilization of 15%. Right? And so your question is, well, how did that happen? Right? Why did that happen? And of course, I'm going to say that because we integrated the EAP into our culture, into our management. That's easy to say, right? In fact, I go back and I write notes about what do I mean by that. Right? I was a managing director at JPMC. That's a pretty hefty title at a bank, all right? And yet they gave it to me. I had access to the CEO. You know him. I had access to people you can't believe. It was that ingrained. Right, that in our culture, it was a part of human resources. It was the way we did business. Managers were trained about it. Managers came. Managers were sent. Executives were sent to the EAP. Well, when you say sent, we all know what means, right? But they were directed, suggested, highly recommended. If you don't have that level of integration, which I took for granted, I don't know how you're going to get beyond that 3, 4, 5%. Just to answer your question, is it enough? It could be, but it probably isn't. I think you have to meet patients or clients or people where they're at, and certainly I am a fan of some of the new digital access platforms, particularly those that preach positive psychology and resilience and things like that. We can get people early on and we don't have to wait for crises.
Thank you. Amanda, your perspective on EAP and whether that was enough?
I would definitely say EAPs aren't enough. I think it's something that individuals and organizations are typically like, hey, we checked the box. We have an EAP, everyone has access to it, they'll know to use it, they'll all love it if they need it. That's not enough. And typically, what I've seen in different organizations too, is that the EAP is a tack-on to something else. So it's probably a tack-on to your life insurance that you offer to everyone. So it's just kind of, hey, we have it, we don't really need to manage it, it's there, it's available. We have a separate EAP from the stuff that's provided, so we have a separate EAP provider. But then we also, Sargento has a strong focus, it's always been one of our focuses for as long as the community surrounding Sargento can remember even. And mental health is such a big thing, that's why we've integrated it into our on-site health and wellness center. That's why anytime we have as part of our teledoc, as part of our medical plan, We also then highlight those providers that are in network, that are telehealth providers that are available for our employees, and we highlight that to our organization. We are a huge sponsor of our local mental health chapter. We are just throwing mental health stuff in our employees' faces because EAP isn't enough in my mind.
Monty, your perspective or your client base?
Yeah, so with working with hundreds of employers, I would agree. I mean, if you get utilization in double digits, you're tremendous. We see single low-digit utilization EAP. Some of it's around branding. We've seen some success if the employers have rebranded the program, working with marketing to get some increase there. But we actually are more focused on something called Mental Health First Aid at Work. I don't know if anyone's familiar with that program or not. It's a national program, but the gist of it is to get managers and supervisors more aware of how to handle someone that's dealing with the crisis. They're not going to sit them down in a chair and counsel them, but they know how to get people into the EAP program or community-based resources. What does the health plan offer? So we've had a lot of success with that as far as mental health from an employer organization.
I will say that I was a believer that EAP was enough. 35 years at the University of Nebraska-Lincoln, we had a fabulous EAP. Being the HR director in athletics, you can see that we sent a lot of people to the EAP, whether it was an athlete or whether it was a coach, whether it was a staff member. Being in the environment that I am now, Vermont, very rural, I feel a little bit like a small fish in a big sea. Going from 7,000 employees now to 180. I can see the impact that having behavioral health, and just one person, I can't do that math in HR, what percentage of that is, and actually when I see our total engagement for our health clinic in and of itself, not just behavioral health, is at 58%. We have been doing this for 1 year. I have people, and I'm not usually as stereotypical, I'm HR, I'm usually very politically correct. I have tough men that are police, tough women that are firefighters, individuals that drive big heavy bulldozers and trucks that aren't the traditional individuals going to EAP or going to the doctor in and of itself, let alone getting, I have those individuals doing that now. And combining the medical health center with behavioral health was brilliant. And I should also say, we have and have always had, as I understand, an EAP. Not saying that wasn't effective. We have also had, for our first responders, we have mental health practitioners that are specifically for individuals for first responders. So to say that it is enough, I am now going to say no, it is not enough to have, and not just the EAP, but you really have to tackle this from as many different perspectives as you can. So when I say, okay, I only have 180 employees, but I have 3 different ways for them to seek mental health, and that in and of itself is making a huge difference.
Thank you. Your thoughts, as well?
Yeah, I would add to the others. And second, it's more than just giving people a point of access, right? I think we all can easily think in our mind of someone that has come to us or someone that we've recommended in our systems of like, I think you should go to therapy. And then that doesn't mean they walk through the door, right? Handing them a number, giving them a list of individuals doesn't result in them utilizing the services. It doesn't result in them following through. It's really all of these pieces that this group speaks of. It's having a culture and a community in your workplace that supports mentally healthy communications, that supports how to handle conflict, problem solving, stress management, work-life balance, all of those things that are involved in your baseline mental health as it may change and shift into mental illness. And then having that kind of quality of access having trainings of mental health first aid, really looking at your populations and members about what those specific needs are. How many of your people, how many of your managers are part-time therapists, right? How many of them have those skills to be able to manage that? How many of you all in this room have felt like that? Do you feel like you have the skills? And then it's really trying to connect them and integrate quality of services and a quality of services that knows your members, whether it's specific for different first responders, whether it's specific for manufacturing and industry, someone or a partner that can work with you to really integrate that in a holistic way across your organizations.
Thank you. Aaron, I'm going to ask a multi-segment question. You can pick up anyone you want. So, assuming we have EAPs, how do you integrate EAP into primary care services? And what does integration really mean?
Yeah, so it depends on the situation, it depends on the vendor, right? Of course, as a psychologist, I live in the gray, so I'm going to start with that. I really think it can start with really that center of that wheel. A lot of times that is your med provider, sometimes that is your HR, sometimes that is different individuals in your organization that can make contact with EAP. I know there are other individuals on this panel can speak more specifically to strategies and ways that they've done it. Of course, you want to respect the fact and make it clear to your members that there's confidentiality in that space, but you also want to have there be a collaboration of care, have there be a holistic patient journey, have it integrated into your marketing, have it implemented into your resources, that it's available, and here's how to get access to that. And really, as mental health clinicians, we want to be integrated. We don't want to feel siloed. That's a frustration that we have as well in seeing patients. So we want to be able to build those connections, whether that's sharing notes, sharing communication, being a problem solver with you all of like how to manage issues or stress management or things that come up within your organization.
Thank you, Dan. How do you integrate the EAP and what does integration mean?
Well, first of all, I'm a big believer in co-location. So I like to see them in the same spot. However, the issue of warning, with all due respect, not any clinician, not any mental health clinician does this well. In fact, our own APA is doing some work on training clinicians how to be collaborative with physicians in seeing patients. I think that throwing any mental health technician into a space might not work. You really got to look for the right kind of clinician that knows how to work in a quote, medical setting, whatever that means to you, and knows how to pair and partner with medical people. Most therapists, I don't think, will do a very good job unless you screen for it and know who to hire and how to do it.
Amanda, your thoughts?
I think integration is key, and what Dan was saying with them being physically in your health and wellness centers, I think that makes a huge impact. The structure of how we have our on-site health and wellness center set up actually is no one, as much as people know who our on-site health and wellness center provider is, we actually got our behavioral health work-life mentors through our EAP, so it actually isn't part of our on-site health and wellness center. We have our EAP that we then contracted with to have someone on site at each of, so we have 5 different locations, 3 of which have a full-fledged health and wellness center, which includes all of our other services, but also includes 4 hours per week of a work-life mentor counselor that's on site that rotate hours between mornings and afternoons. And they do that from the standpoint of the fact that we have 24-hour operations, so those are around the shift change times that they switch back and forth so that there's access to those individuals. As much as everyone hates the stigma of an EAP as well, we have to address that no one wants to walk into an office and be like, I need EAP, or they don't want to be seen pulling the EAP information off the wall. They don't want to see any of that. It's really integrating all of those services, so our employees don't know that our on-site health and wellness center work-life mentors are actually part of our EAP provider. So they're actually part of that. And then we also do an integrated, we have like business cards that are kind of in the bathrooms or they're in common locations that have all the different kinds of resources. So it includes Mental Health of America's links. It includes the suicide line. It includes whether you're on the medical plan or not on the medical plan. It has all those services just on this little card, so someone could be grabbing that card for a million different reasons. And it's just a great way to kind of get people thinking like, they might be taking that card, but you kind of remove that stigma a little bit because you're integrating it with all the other services, whether you just needed the Health and Wellness Center phone number. So that's kind of how we've integrated all of our services to kind of make it, hey, here's all these services, but don't be afraid to grab that card because you might be grabbing that card because your kid has a sinus infection, but you also could be grabbing it because you really need those mental health resources.
Thank you. Monty, how do you integrate EAP and what does integration mean?
Well, I'd say integration means a little bit something different to me. So prior to Marsh, I worked in the accountable care, value-based care world and worked with 25 large health systems nationally. And a number of these had built a significant infrastructure around population health and data analytics to support that transition. And they were successful in that world. And they also had on-site clinics for their employees. And some of the best outcomes were actually from the health systems that had the clinics for the employees that had integrated services. So they had on-site, they had not only the physicians, nurse practitioners, but they had social workers, they had pharmacists, they had mental health resources, case managers, et cetera. And when you looked at the cost, the utilization, the outcome metrics, they were far, far advanced over what you would see in the rest of the healthcare landscape in the U.S. So to me, that's what integration looks like, is more the multidisciplinary care team approach in the clinics.
Thank you. Daisy?
I'm going to take a little different perspective and talk about, we started a new mental health clinic. We included behavioral health. We needed that program to be successful. So how do we engage our employees to utilize the services? And I think one of the ways that we were really effective in that way was inviting those team members to become part of our wellness committee, to attend all of our events. So for example, during the summertime, we have employee events once a month. So July, we had an ice cream social. Our marathon folks, our behavioral, the nurse practitioner, the med assistant, they were all there at a table, handing out sunscreen, talking about sun protection that month, getting to know all of our people. And then the same thing at the barbecue we had last month. They're sitting at a table, they're taking blood pressures. Anyone that got a blood pressure got their name in a drawing to win a free blood pressure cup, or a free blood pressure machine. I was the winner, thank you very much. I will say I'm going to re-gift it at our next event because I do already have one. So before I can say, no, draw another name, they were all saying, oh, thank you, here you go. So yes, I think part of our success is integrating those individuals into the everyday lives of our employees.
Great, thank you. Daisy, hold on to that. So let me ask you, how do you reach the hybrid populations, the people who are working remote or separate with behavioral health services, again, tied back?
Sure, I was very curious about the amount of people that we see remotely versus versus in person. So I literally during break ran upstairs, pulled up my computer, pulled up the reports the Marathon gives me every month to try and determine who do we see and how do we see them. So 80% of our people that we see are still clinical, they're still face-to-face. 20% are virtual, so they're hybrid, they're seeing individuals via Zoom, on Teams, remotely. And believe it or not, we have people that still use the telephone. I couldn't believe that. I mean, granted, it's only 2 people, but why are they still using the telephone? So again, it's just reinforcing that you got to hit them from every angle. You have to remove those barriers, as many as you can. And if it's still a cell phone call, which I will tell you can be a challenge in remote, believe it or not, coverage, yeah, I could not sit in my living room and have a phone call. I had to go to my upstairs bedroom by the window in order to get, and that's even with using Wi-Fi for cellular. So believe it or not, it's still a struggle in some parts. parts of the role. But yeah, I think the impact that you have has to be to offer as much, and really if you think it's out of date, the telephone is still a very reasonable thing.
Aaron, how do you recommend we reach our hybrid workforce?
Yeah, I agree with Daisy wholeheartedly. I think it's really about giving all types of offerings to individuals of ways that they can have services. I think especially for therapy, it's relationship based. So it really is about people feeling like that's a safe space, and whether that happens in person, whether that happens virtually, and it's really wanting that consistency as well. I think that's something that we hear a lot from individuals when they're in that kind of emotionally vulnerable space. You want to know it's someone that you can see consistently, so there are those options. If I can see them virtually this day, I could come into the clinic this day if I don't feel like I have the space in my own house, or I don't want to have that conversation in transit, or any of those kinds of things. So I really think it's about having those relationship-based types of service offerings, and it's really having those relationships with your members as well, that they feel like they have that connection, even if they work remotely, if you have a hybrid workforce. I think we all can recognize the workforce is changing, right? Due to pandemic, post-pandemic, it's a different workforce, and there are a lot more expectations of what people are expecting our workforce to fulfill. And one of those is really having more of a relationship, more of an investment in their mental health and their overall emotional health, and really being able to still build those connections with your workforce and have those relationships, and really to have conversations about those access points consistently.
Thank you. Dan, how do you reach out and engage?
Interesting side note, I'm still in touch with a lot of friends who work in the financial industry, and right now the new stressor is come back to work, right? Particularly in the financial industry. So we're bringing folks back, and that's the new source of post-pandemic stress coming back. But speaking specifically, with regard to work-type healthcare centers, as we're talking about, one interesting thing that happened as a result of the pandemic, we talked about all these things, is that we know that telehealth, particularly for mental health, jumped up in about near the beginning of 2021. And unlike most of the primary care and other health specialties that have decreased, it has stayed pretty consistently high, relatively speaking. So I can't duck that, all right? And it seems that particularly for those people who are located far away from a hub or a work site, I have to be brought in kicking and screaming and understand telehealth as it applies to behavioral health. So far, the results say that they're using it and they like it. There haven't been great studies that talk about the fact that it's not as good. In fact, most studies would say right now it's just about as good, except for serious mental illness problems. So given that fact, I would probably right now be working on a telehealth campaign, really normalizing it and explaining it for those people who are remote, as opposed to close to a worksite health center.
Amanda, how do you address that?
Yeah, with our on-site health and wellness center, so with us being rural in Wisconsin, halfway between Milwaukee and Green Bay, here we are. So we're really in a rural area where care is hard to find. Not that it isn't hard to find in big cities and all of that, but we truly are in a desert. We have 5 locations, all of which are within a 45-mile radius. If you go to our newest location, you're literally traveling 10 miles in the middle of a cornfield until you hit it. So that literally is the population that we're working with. Yes, we do have sales force across the nation, but that's a very, very minute population. And as I mentioned previously, we have 3 of the locations where a work-life mentor is on site. That kind of silos to those different locations. But because we are aware of that, we also offer those work-life mentor services as a virtual option. So if there's an employee who's at our Plymouth location and they actually prefer the work-life mentor that's at our Hilbert location, they can do virtual out to Hilbert, or they can go to the Hilbert location if they would like. Like I said, all of our locations within a 45-mile radius. So they can choose to do that, but if they want to and they develop that relationship, they can do it virtually. So our work-life mentors do operate either mode of transportation, if you will, and the fact that you can come in on site if you feel like you want to talk to that person today in person with them face-to-face, you're you're more than welcome to do it that way, but you're also welcome to schedule that appointment as a virtual option as well, which brings the access of care to our entire population, regardless of if they're living in LA, in a sales group, or if they're right, in our hometown with Plymouth, so.
Thank you.
How many employees?
We have 2,500. So we're pretty small, but we're mighty.
I think you're-
It's great cheese, so go on. Yeah, so virtual care, we looked at about 1 million people during the pandemic, and if you're looking at what services to provide virtually, the 3 top drivers were behavioral health. Certainly there's a privacy and access issue that virtual behavioral health can help solve to some degree for. Physical therapy, people didn't want to get in their car and drive 5 times a week to the physical therapy office when a lot of this can be done virtually through point solutions. And then dermatology, and you may wonder why dermatology was a big driver during the pandemic. Well, think about it, stress and the effect of stress on acne and skin conditions, as well as everyone was wearing a mask all the time. And so there was actually something called mask rash, which is very prevalent. So I don't think it's going away. I'm a physician and a surgeon, and there are obviously going to be patients that still need to be seen face to face. Multiple chronic health conditions may not be the best fit for virtual healthcare. As far as the best model, I'm a big proponent of the hub and spoke model. So you think about school districts where maybe there's a central clinic, but the different schools can access that through a kiosk or a virtual touch point. Same thing with retail. We've got a lot of clients that got shops all over the country, and if they can access that, the main clinic through a virtual kiosk, that's another great way to approach this segment.
Thank you. Hold on to that, Mark. Let's start with your next question. Okay, so virtual care is here to stay, but there's 1 million of them. We actually are now as part of a group called Impact, or the Virtual First organization. And every week there's another 20, 30 vendors who are focusing on this area, particularly behavioral health, mindfulness, etc. So what is the role of all these digital tools? Are they valid? And how do you integrate them again with the center? Or do they, again, another fragmentation? You've got some of your populations data.
Well, I think as far as the evolving landscape in healthcare startups, so we do one thing at Marsh. We've got what's called a vendor innovation council. So in the last year and a half, we've met with probably 80 vendors. These are startups, these are established companies, and we try to understand from the employer perspective how these programs work. Some vendors don't work with the smaller employers. What's their pricing? What are their outcomes? And then we share that information with the clients. I'm a huge believer. I know there's a lot of debate around artificial intelligence and predictive analytics, but I really think that's going to change the healthcare benefits perspective. I mean, when you think about yourself and how you're choosing your health benefits, most of us just flip the switch. We spend 5 minutes because nothing's changed our condition. We like our health plan, we like the other benefits, so we do the same thing year in, year out. But think about it, if you knew that your risk of becoming a diabetic in the next 5 years was going to triple, or you have a 10% increased risk of being diagnosed with breast cancer. So maybe you think about your benefits differently. You contribute more to the HSA, you participate in the wellness program, you get your screenings and so forth. So I really think that's going to change. And then, we work with self-funded employer groups, and they need to be able to predict and forecast what their costs are going to be to plan strategically. So if they knew their diabetic population was going to double in the next 5 years, maybe they implement a point solution like Livongo, or maybe they manage the diabetics in the clinic or something like that. So data, artificial intelligence, predictive analytics, really going to be huge in the next decade, I think.
Daisy, what's the role of the digital tools and how do you integrate them into your center?
I'm sitting here listening to Monty talk about diabetic breast cancer survivor, and I'm like, oh my gosh, I am diabetic, wearing my monitor right now. I love the ability to, I just have a monitor that now sends me alarms. My very first alarm, I was like, what the heck is that? My phone is going, I don't normally go though. But what had happened is my monitor had come off. So it's telling me my blood sugar is 35. Yeah, that was totally wrong. So I am a very firm believer in integrating digital medicine because it is really helping me to know that, okay, I may have a blood sugar level right now, but I'm going to eat that piece of cake. So I have to be a little proactive with what I do. But, and I've forgot your question. So it's
How do we integrate digital tools?
Yes, digital tools are the way of the world, especially now when our children are I'm sorry, I'm the generation where I was the best VCR plugger and could hook it up. You know, I had to show my parents how to use a VCR. But now, when my 8-year-old was showing me how to set up my contacts so that my Wi-Fi would look at me, yeah, no, I am not that. So, and I'm very ashamed of that. But when we have these new technologies that are going to make things easier and more available and remove barriers, again, I think we have to take advantage of everything that we can.
Thank you. Erin, how do we use these and integrate it?
Yeah, it is a very new space for mental health. All of the options that are out there didn't exist a couple years ago. So in many ways, I think we don't know yet, even research-wise, clinically, what is going to work for the best for people, how much access is too much access, what kind of care do people need, what type of modalities do they need. I think current state is really making database decisions, having real conversations about what people are actually going to use. So when we talk about digital options, if you're working with or have members that aren't utilizing the digital options that you've already given them, if they aren't using their corporate email and they're not going on the webinars or the virtual lunch and learns, the likelihood that they're going to utilize an all virtual telehealth option for behavioral health is going to be difficult, or it's going to be a heavy lift to get people to invest in that. So it's looking about and really making database decisions and also the type and the research-based clinical care that your members need. And a lot of that is just learning and gaining that information. There are a ton of resources already out there, good and bad, in terms of mental health. You can go online and social media and find all kinds of ideas of how to manage your mental health, and some are great, some are not so great. It's really learning more about what are the different mental health professionals that are out there. What's the difference between master's level clinicians and psychologists and psychiatrists and psych MPs and health coaching and life coaching and all of those different things, and really looking at it from that mental health spectrum that we talk about when it comes from skills of just managing all of our mental health, and then what type of therapy services do you need when people get to a place of mental illness or significant mental health symptoms that are interfering with their day-to-day functioning, that are interfering with their ability to manage their lives, and what types of assistance is needed for that, and what kind of digital solutions are the best for those needs. And I think there are lots of options out there, and it's really making database decisions and using discussions about what's going to be the best and the most responsible in terms of using for your members.
Dan, your perspective?
You know, I'm retired and old and crabby. Reflecting on what you said, Larry, and what Erin just said, I think we are approaching a saturation point in the market with respect to these digital, whatever they are, therapeutic endeavors. I am deeply suspicious of most of them because I have looked behind the curtain and I kicked the tires. You should be deeply suspicious of these digital therapy things. Having said that, as I already mentioned, I do believe that a very good and broad-based digital resource for health and well-being is essential. As I mentioned before, it helps people find what they need when they need it. That should, in a sense, empty into or direct into either an EAP or your worksite clinic or whatever you're using your behavioral health care benefit. It should be able to pour into that. Maybe they'll be better in a few years. I would just warn you that with many of the digital therapeutic aids out there, look behind the curtain. Ask who are the therapists, ask how are they getting paid, how many patients they're seeing, what constitutes being seen. I'm suspicious.
Fair enough. All right, my last final question for the panel, starting with Amanda. What are the success factors for integrating behavioral health with primary care?
I think some of the biggest success is when you have an on-site health and wellness center or near site health and wellness center, that all the providers are aware of all the services that are offered through that on-site health and wellness center. We'll constantly be educating our providers and those who are the ins and outs of our on-site health and wellness center to remind them, hey, if you're working with a patient and you notice anything, whether it's a mental health thing or maybe it's, they're having a certain pain, we have those physical therapists. Refer within so that you guys can manage this individual as a whole versus taking it just as a point solution within your on-site health and wellness center. So making sure that your vendor partners that are involved in your on-site health and wellness center and your site health and wellness center are all integrated so they're aware of all the solutions that are there. Because the worst thing that you can do is have an NP who's working with someone who has mental health struggles or they can see that they're stressed about something and they don't even know where to refer them, but yet the exam room next door has a work-life mentor 5 hours or 4 hours a week and whatever that isn't being utilized to the maximum capacity. And also taking it to the next level and making sure that frontline supervisors and your frontline HR representatives all are also overly educated in this topic as well. We've had many times where we call them our employee experience team, which is our HR kind of frontline individuals, where they'll come and they'll be like, hey, this individual said they can't get into the EAP or they can't find help, whatever. Have you mentioned that we have an on-site provider with our work-life mentor? Oh, I forgot about that. Like, that's an easy, quick referral process that just making sure that your supervisors and your on-site health and wellness center providers are all aware of every single benefit that you offer so that they can be sure to get the people to the right individual at the right time exactly when they need it.
Thank you. Monty, success factors?
I think it starts with data and ends with data, and I think you have to have data to prove the business case for investing in behavioral health in the clinic. And I think what you want to do is go beyond medical and pharmacy eligibility data and take in disability, absence, leave management data, 401k, retirement, take in workers' comp, and be able to show that the care that people are receiving for behavioral health or any chronic health condition, the care that they're receiving in the clinic is actually better than the care they're getting out in the community. Whether you're looking at cost, whether you're looking at utilization, or you're looking at risk, be able to show that care is better in the clinic. That is a strong, metric that we leverage with the C-suite to validate the investment, the capital investment, the human investment in that clinic. So I think being able to look at data and show that people that utilize the behavioral health in the clinic, they're back to work sooner when they go on short-term disability, or the workers' comp claims are less because people aren't distracted at work and falling and so forth. So data.
Thank you. Daisy, what's your success factor?
I got a D in stats. It's the only D I ever had in my college life. So I sit there and I listen to Monty talk about data and being an HR person, that relationships are all what I do, what I live, eat, and breathe. He's right. But when you think about data in this type of scenario, we're talking about, return on investment, ROI. In this situation, are your people. They're your employees. We're talking about their well-being, their health. Not only are we talking about that, but we're talking about how they, when you have that foundation, they're more productive. They come to work. So marrying these things, it's not one or the other. It's not. It all impacts the other. So I think success also is remembering the why, and growing up in the HR world, and I am curious, how many people do a little bit of HR or all HR in this room? I'm used to being at HR conferences, so I'm not used to, yeah, absolutely, I see a lot of hands up. HR is kind of it used to be check the box. tell people, yeah, you know what, there's an EAP, you should make sure you know, yeah, I just fired you, you know, in difficult situations. Here's a phone number that you can call, because they can help you with the stress life of going to try to find a job. So yeah, remembering the why, remembering that the data is also the why.
Thank you. Erin, your success factor.
I'll try to combine both of those. I think there's quantitative and qualitative. I think having some kind of assessment, whether that's your chronic conditions that are seeing multiple services, right? We see the biggest gains with people medically when they're able to also see behavioral health, when they're able to also see health coaching or a PT, when they're able to engage in wellness programming and see their primary care and manage their diabetes, right? They're all related to each other. So really seeing the reduction in those chronic conditions, I think takes that integration that can prove successful. I think it's giving some baseline assessments with whatever behavioral health solutions you hopefully pursue with a PHQ, with a GAD. Those are kind of our foundational depression, anxiety, self-report assessments. Seeing those kind of changes, doing stress inventories, all of those things that are included that can give you some data back above utilization, right? Give you some more specifics about your individuals that you're working with. I think qualitatively, to Daisy's point, it's hard to pull ROI for mental health. As Dan and I can speak to, we can't do that across the board for mental health, no matter what organization you work for. We've been told that a long time. So I think it's really about the word of mouth, the culture that you're able to see people talking about stress more openly, or talking about their work-life balance, or being able to just be more invested in your organizations and companies, and retention and presenteeism and absenteeism, being able to see that people are more present when they're at work, that they're more productive, that they're more present, right, more invested, and they're reducing their absenteeism as well.
Thank you. And finally, Dan, your success.
Going back to, the original aspect of integrating, and I assume we were talking also about integrating vendors here, right? First of all, something we've gleaned from Health Next. Scott, where are you? One thing we've discovered in working with employers, and we have a pretty rigorous assessment device, is that integration and navigation is the area in which most employers score the worst. Don't worry, it's not reflecting bad on you. It's just, it's the most difficult, right? Getting vendors to really back up their claims of working together, all right? And what that means. And the data in this case that we need to see is, how are cases going back and forth? How are you referring? How are you genuinely, warm-handedly moving patients from where they are to what they need? So when it comes to integrating vendors, I can tell you that it is what we found so far to be the universal pain in the neck. It's very difficult. I don't want to be mean to vendors. I'm a vendor. But you really need to stay on them about how they are integrating the patient care and making sure that things get passed in the right way, and then using the data to prove that in a sense, I hate to say things get passed, because I'm really talking about how people get passed, right? And that they get passed correctly and warmly and lovingly, and it's done right. It's tough.
Great, thank you. All right, we have questions from the audience. I'm going to ask, not everybody has to comment, just quick responses, because we've got about 4 minutes left. Okay, let's start out with, how does a small employer with less than 500 deal with behavioral health issues?
I think 180 is less than 500.
That works.
Yeah, that would be me. That's the spotlight on David. From every direction possible. From new employee orientation to the new people coming in, to the people that have been there for 30 years, to the families of them. They don't remember and they don't think about it until they need it. So when their child has been diagnosed with ADHD and they now are in the place of needing to find someone that's, you just do it all from every direction all the time, and even though you think you're pounding sand, you really can make a difference.
Okay, thank you. Amanda, can employees make an appointment through your clinic if they are not part of the clinic?
So all of our employees at Sargento can use our on-site health and wellness center. There's no eligibility requirement. You don't have to be part of our medical plan in order to use it. So as long as during good old open enrollment and anytime basically throughout the year, if you find the right person, as long as you enroll yourself, you can, well, which by default, all of our employees are auto-enrolled into our on-site health and wellness center, but during open enrollment, they can also add their spouse and their children up to the age of 26, and they can use all of our health and wellness centers. So like I said, we have health and wellness centers at all of our locations, except for our newest one, which we acquired in June, which doesn't have one yet, but there's already slated plans to add a health and wellness center there. You can, if you're in Plymouth and it's more convenient to go to the Kiel one or the Elkhart Lake one or the Hilbert one, go to whichever location you want. So you don't actually have to go to the health and wellness center at the location that you work. So for example, no one knows these cities anyways, but in Plymouth, I live between Plymouth and Kiel. Sometimes it's easier for me to take my kid for a sinus infection at the Kiel location, so I'll take him to Kiel. I work at our Elkhart Lake location, so it's one of those things that you can really utilize any of the locations if you want. That's the nice part about being within a 45-mile radius, is really, it depends where you live, depends where you work, what's convenient for you, but we have no criteria for anyone who uses it, and our behavioral health is at zero cost for our employees and their dependents.
Thank you. This is open for the panel. Are you seeing employers allowing employees to utilize mental health services during work hours?
I'll take that one. Depends. There are so many barriers to accessing mental health services right now. I would advocate for removing as many as you possibly can. So we really strongly encourage any employers, clients that we work with, to have it be available during work hours. If that's not possible, I understand. I think at least having some kind of communication, policies, whatever you kind of want to term it as, that people are not penalized for going. So a lot of times, especially if we're working more with manufacturing, industrial individuals, if they stay on the line, they get extra overtime hours, extra pay. So why would I leave when I can make more money staying? So there's a little bit of like not getting points off or not losing extra points to go to mental health appointments or any appointments. We also try to really have availability that lines up with shifts. So if we need to swing or you need to talk about specific solutions that are more available when people are going to maybe be near the on-site or near-site clinic, right, when they're driving by and can stop in, having more availability, walk-in sessions, things like that, beginning and ends of shifts, or really just having virtual options as well.
Last one I have on my text. Regarding access to mental health services, has the panel seen any success in a text-based model, including AI, that responds to questions from employees?
I've not seen any research that shows it's successful. None.
Yeah, I think Dan and I are probably on the same page about this one. We'll see. Maybe I'll be a little gentler on it. We'll see.
When you get older, you don't lose your filter.
So my research hasn't backed them up, all right? Maybe it will. I agree totally with what you just said, Aaron said, but it's not there yet, all right? Although we have a satisfaction report, which is not the same as clinical efficacy, right? I liked it. That's good. That's important. That's not the same as it made me better, right?
I'm sorry, Aaron, go ahead. I'll stop.
Oh, I will say in favor, when it comes to being able to have access, right, when you're at a point that you want somebody to talk to, it depends on severity of symptoms. When it's lower level of symptoms, lifestyle management, wellness programming, health coaching, a lot of them can be helpful in terms of behavioral change, behavior management, and accountability. I think there is some nice research on that. When you get into significant mental health symptoms management of more of those really mental health disorders, not a lot of research that it's been as successful and long-standing for behavioral change.
Monty, your perspective?
Nothing. I mean, I would agree. It's pretty immature, I think, with some of the artificial intelligence. But I think, like you said earlier, 5-10 years from now, it's a different story on that.
Okay, question from the audience.
Dan, with regard to integration of behavioral health into a medical setting, you mentioned co-location, putting a person physically in that setting. However, the problem is communication between the medical provider and the behavioral health person. In other words, they're on two different worlds, and they often are not co-managing employee. Do you have any suggestions or found any ways to help improve communications and co-management between medical and provider?
You know, first of all, it is relationship management, right? I was a part of arguments between physicians and behavioral health care experts. I was involved in firing either of them. I know sometimes it just doesn't work, but it requires somebody who's in charge who tells both the primary care doc and the behavioral health specialist that they have to work together, and in fact, even making sure that they have time to work together and coaching both as to how to work together. That's kind of what I was getting at before. The idea of dropping a doc and a social worker in an office and saying, have fun, you two. You know, it doesn't always work that well. You really got to manage it until we get to a place, in the United States at least, where we're doing much more, home-centered, that nice word that uses home to talk about. Yeah, that's it. Until we get to that spot where more physicians and more behavioral health care people are really working together, we're still learning how to ride that bike. We really are.
Yeah, that's a great point. I just think from a medical education perspective in this country, I mean, when I trained, we got very little training in behavioral health. We had a 6-week rotation in medical school. I think that's got to change. We've got to educate the physicians and nurse practitioners, other providers coming out into the system to be better able to handle mental health. Because it's just gonna, this is something that's gonna be with us forever, and it's gonna get worse. So the system right now is not capable of handling the challenges. I don't think.
Any other questions? If not, let's please thank our panel. Okay, we're going to give you a series of instructions now. So lunch is served out here. Please grab that, bring it in here. We're going to have lunch between now and 1:30. After lunch, right here, we're going to have our Board of Elections and the NAWHC update. Then at 1.